I'm Michael Narkewicz. I'm a professor of pediatrics at Children's Hospital of Colorado and the University of Colorado School of Medicine. It is my pleasure today to present an American Liver Foundation video series for providers on hepatitis C virus infection in children and adolescents. I will be presenting today with my co-presenter, Vania Kasper, who is an assistant professor of pediatrics at Brown University. Here are my disclosures. I have funding from NASPGHAN, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition for this presentation, and research grants from Gilead and AbbVie, which are directly related to hepatitis C therapies. I also serve as a consultant for Vertex, which is not related to this presentation. I'm going to pass this off to Dr. Kasper, and she'll take you through the first half of this presentation.
I also, for my disclosures, received funding from NASPGHAN for this presentation. So I'd like to start with an introduction to hepatitis C infection in children. The hepatitis C virus was discovered in 1989 and was quickly realized to be a leading cause of liver disease, leading to either adult liver transplant and or adult liver cancer. This made this a very important virus to understand, and much research went into describing the virus and understanding its pathophysiology. And we subsequently were able to develop very highly effective treatments for hepatitis C. Our knowledge of HCV infection in children has also just exploded over the last 2 decades, and this has helped to motivate testing and treatments moving down into the pediatric age group. So our objectives today are to understand the natural history, presentation, and epidemiology of hepatitis C infections in children, to know when and how to screen newborns of a hepatitis C positive mother, understanding the modes of transmission and prevention of transmission, and to understand the current recommended therapies for children with chronic hepatitis C infection, understanding when to start treatment, what treatment, and why. So in children and adolescents, the liver disease that occurs in a hepatitis C infection is typically mild in those who fail to clear the virus. Some patients will clear the virus. There are a few risk factors that I'll go over in the next slide, which does predispose patients to having a more severe disease course. The complications that we see from advanced disease, such as portal hypertension and its sequelae, and hepatocellular carcinoma, which have prompted so much concern in adult patients, are rarely seen in pediatric patients. However, liver transplant has been reported in the pediatric population, but is exceedingly rare. So these are some of the things that we know result or can lead to a more severe clinical course in a pediatric patient who has hepatitis C virus. Obesity, patients who have survived cancer, patients with congenital anemia requiring transfusions, concurrent infection with HIV or hepatitis B, IV drug use and alcohol use, homeless adolescents who are more prone to having risky behaviors and have limited access to medical care, and adolescents who are incarcerated. Many of these children with hepatitis C infections are asymptomatic, as with the adult population. Most children will, if tested, have intermittent or mild elevations of their AST and ALT, but importantly, these elevations do not appear to correlate with liver histology. Hepatomegaly in one study was found to correlate with higher levels of hepatitis. However, again, this does not correlate with more severe disease on histology. And finally, the extrahepatic manifestations that we see in adult patients, such as glomerular nephritis or cryoglobulinemia, are rarely seen in children. Hepatitis C in adults is found around the world. An estimated 72 million people are infected with this virus, leading to approximately 400,000 deaths annually. In children, published prevalence rates suggest a rate of infection of 0.5 to 0.36% in the United States and Europe, and increasing in developed countries to 1.8 to 5.8% prevalence. We, however, think that these are underestimates because of suboptimal ascertainment or testing practices that underestimate the true prevalence. We know that identified infected children only reflect a small fraction of those that we expect to see knowing adult prevalence. Schmelzer and colleagues created a modeling system looking at published prevalence data from 25 countries around the world and used additional data from other countries in adult prevalence to come with a prevalence estimate including 104 countries and 83% of children in the world. And they estimate that there are over 3 million children who are infected with the hepatitis C virus. Part of this prevalence is driven by adult prevalence. There is an association between the prevalence of hepatitis C infection in adults and those in children 5 to 19 years of age. In children under the age of 4 years old, the prevalence of hepatitis C infection in women of childbearing age is the strongest predictor of the children being infected. And the proportion of hepatitis C infections in people who inject drugs is significantly associated with the prevalence in 15 to 19-year-olds. Moving on to testing, we have 2 forms of testing available. The first is the hepatitis C antibody, and the second is hepatitis C RNA PCRs, and these can be qualitative or quantitative. There's a recommended screening sequence in which we start with the hepatitis C antibody. If the antibody is not detected, the patient is not considered to be infected, and you can stop screening at that point. The caveat with this is that if a patient has been exposed to the hepatitis C virus within 6 months prior to the test, you may consider repeating the test to confirm that it is truly negative. If the hepatitis C antibody is positive, then many labs will reflex to the hepatitis C RNA PCR. If the PCR is negative or not detected, there is no current hepatitis C infection. And again, the caveat of recent infection goes into play with considering repeat testing if there has been a recent exposure. And if it isn't detected, the RNA is detected, then the patient has a current hepatitis C infection and should be linked to ongoing care for assessment and treatment. This slide shows on the x-axis time after birth, so on the left-hand side in months and the right-hand side in years of an infant, and on the y-axis their antibody titers. The small dotted lines that are sloping down towards the right-hand side of the screen are the maternal antibodies, which do cross the placenta and are present in an infant, with levels finally disappearing by 18 months to 2 years of age. The larger dashed lines are the infant antibodies, which develop over the same time period. So testing is recommended at 18 months to 2 years of age to be clear that to be sure that the antibody detected in a test is actually infant and not maternal. The U.S. Preventative Services Task Force has recently changed their recommendation for screening in adults. This figure is pulled from an explanation of that. And on the x-axis, we have time in years, on the y-axis prevalence, so cases per 100,000 population. And what you can see at 2010 is that we have a skyrocketing incidence of cases in 20 to 29-year-olds and 30 to 39-year-olds. And this correlates with the opioid epidemic in the United States. So the U.S. Preventative Services Task Force has changed their recommendations as of 2020 for screening in all adult patients 18 to 79 years of age at least once during that time period, so that we can hopefully catch more of the patients who have a silent infection, treat them, and prevent transmission. Correlating with this, the mean number of live births affected with hepatitis C virus due to perinatal transmission are also rising. So again, x-axis has time and years, y-axis is number of births of hepatitis C affected children or infants, and we have a over 240% increase from 2010 to 2017. Unfortunately, although we have many children and infants who are exposed to hepatitis C, many of them are not being identified. This study by Lopata and colleagues in Tennessee used a Medicare database to retrospectively look at infants born to hepatitis C positive mothers, and 75% of infants were never tested for hepatitis C, despite their being born to a mother who had hepatitis C. So this is another area for us to be improving our diagnostics. Some of the children who are exposed to hepatitis C will have a spontaneous viral clearance. This typically occurs before the age of 2. After 2, there is still a chance that they could clear the virus on their own, 6 to 12%. However, there are reports of children who have spontaneously cleared the virus and yet have a recurrence later in life. So it is important not to ignore these children after they have cleared the virus, but maintain some sort of contact with the family and consider viral reactivation if they are showing any signs of liver disease. And it is cost effective to screen patients. Asimo and colleagues have done several studies looking at cost effectiveness calculations. And in this study, they looked at one-time screening in young adults and adolescents. They used 9 different permutations of a combination of routine screening versus directed screening based on risk factors, physician ordering versus counselor ordering of the test, and then rapid test results versus traditional venipuncture results. And they found that the most effective and cost-effective method was having routine screening of all adolescents and young adults who presented to this care center, with a counselor being able to initiate that testing and rapid testing used to offer immediate linkage to care and further treatment. And with this, I will turn it over to Dr. Narkewicz for more information.
Thank you, Vania. I would like to mention that both Vania and myself are members of the American Liver Foundation Medical Advisory Committees. Vania is a member of the Northeast chapter, and I am the member and chair of the Rocky Mountain chapter of the American Liver Foundation Medical Advisory Committees, and we're very happy to bring you this presentation today. I'd like to transition to a discussion about prevention. So hepatitis C transmission needs to be understood to understand how we can proceed to prevention of transmission. For children, there are two major forms. For young infants and young children, the major form of transmission is vertical transmission. Vertical transmission means transmission from a pregnant mother to her infant. In the older child and adolescent, the major mode of transmission and the only mode of transmission is horizontal transmission. And as Vania pointed out, this has increased with the opioid epidemic. There are risk factors for mother to child vertical transmission that include viremia, maternal HIV co-infection, and maternal drug use. There have been some possible risk factors where there might be slightly increased risk of transmission associated with either invasive testing, prolonged rupture of membranes, or obstetrical procedures. Importantly, there are factors that are clearly not associated with transmission, and that includes the mode of delivery and breastfeeding. I'll talk a little bit more about these in depth. So, of the established risk factors, maternal level of hepatitis C virus is a major factor. The higher the virus level, the higher the likelihood of transmission. Although globally, the transmission rate is about 5% for all pregnancies where mom is infected with hepatitis C. Our current strategy is to identify moms or potential moms ahead of time and treat them prior to conception. In the rare case now where you have to use a ribavirin-containing agent, then the potential mother should avoid pregnancy for another 6 months after finishing ribavirin therapy because ribavirin is a teratogen. Currently, there are no antiviral therapies approved during pregnancy to prevent transmission, but I'll show you some exciting information shortly. If a mother is HIV infected along with hepatitis C infected, there's a twofold increased risk for the transmission of hepatitis C, upwards to 10%. We believe this is related to that HIV-mediated immunosuppression, leading to very high HCV viral loads. So a treatment attack for this is to treat mom for her HIV co-infection to reduce that risk. And then for reasons that are a little bit unclear, maternal IV drug use has an increased risk of transmission also. What's not associated with this risk? The hepatitis C virus genotype and the mode of delivery. So initially, individuals were felt that maybe a cesarean section would reduce the transmission, but that is not the case. And so routine cesarean section delivery for HCV infected mothers is not advised, unless there are obviously other medical reasons for this. And there seems to be no difference in hepatitis C transmission between HIV negative women with C-section or vaginal delivery. For HIV co-infected moms, the use of C-section should be guided by their HIV status. What about breastfeeding? This is a very common question we get in pediatric hepatology. Although hepatitis C RNA has been found in colostrum, acquisition of hepatitis C via breastfeeding has not been documented. A couple of factors might contribute to that. One is it's believed breast milk may inhibit HCV infectivity by disrupting the viral envelope, and the swallowed virus is very likely inactivated by stomach acid. One exception to this is if the breastfeeding mother has cracked nipples or bleeding nipples, they should abstain from breastfeeding until that is resolved. So what's on the horizon for prevention? I mentioned this briefly before. If we could treat pregnant women who have high hepatitis C viral load, we believe that we could prevent transmission to their infant. So studies are underway to look at whether the current direct-acting antivirals, such as ledipasvir and sofosbuvir in this particular study, can lead to reduction of hepatitis C virus in a pregnant mom and be safe to their infant. So here's a result from an initial phase 1 study. On the x-axis is the time through pregnancy and then after delivery. On the y-axis is the log level of the hepatitis C virus. And you can see with institution of therapy, there is a rapid decline in the hepatitis C virus load, such that by the time of delivery, it is very low and at a level which we would predict there would be no transmission. Certainly more work is needed, particularly around the safety for this for the fetus and subsequent infant. What about horizontal transmission prevention? So this is a common question we get in families where a child is infected with hepatitis C before they undergo treatment. So hepatitis C is not transmitted by casual contact between children. It's children who are infected are not a significant risk to other children. There should be no restrictions in school sports and athletic activities, except that if there's active abrasions, they should be covered such that bleeding does not occur. We do see, sadly, upon occasion, discrimination and stigmatization in school and child care settings with disclosure of hepatitis C status. And for that reason, we believe that and recommend that families should not be forced to disclose a child's HCV infection status, and there are no legal requirements for them to do that. My personal practice is to advise families to potentially have a discussion with a school nurse around this issue, but that is really left to the discretion of the family. How can it be prevented, though, in schools and athletic events? Well, universal precautions, both at school and at home. These precautions should be in place for any blood that becomes apparent at an athletic event due to a cut, scrape, or an injury. And so avoiding that is not only good practice for individuals who have hepatitis C, but for all individuals. At home, we also advise avoiding sharing implements that may have blood exposure. For my practice, that includes razors, toothbrushes, and nail clippers. In the case of a blood spill or a bloody nose or a cut, we recommend that parents use gloves to clean up the blood, and they can use a 1 to 5 solution of bleach left on the blood for 5 minutes, which will inactivate the virus. Vania talked on the fact that adolescents are increasingly infected with hepatitis C related to the opioid epidemic. Well, how can we prevent that transmission? Well, obviously, the best way would be to avoid those high-risk behaviors. So recommending against self-tattooing, piercing, sharing needles, IV drugs. If we look at sexual transmission, the risk of transmission is very low or rare unless there are HIV-infected men who have unprotected sex with men. Be that as it may, we encourage barrier precautions in all of our adolescents for this. I'm going to shift to treatment. Prevention can be effective and is an important cornerstone to this, but treatment is where significant advances have been made for children. This is a timeline of the development of hepatitis C therapy. And that the year is shown on the x-axis, and the percent cure, which is sustained viral response rate, but I think we can generously use the term cure, is shown on the y-axis. Starting in the 1990s, shortly after the identification of hepatitis C, interferon became available. Combining this with ribavirin in the early 2000s led to an improvement in cure rate to about 30%. Slightly improved with pegylated interferon and ribavirin. These are all of historical interest because those therapies were very taxing on adults and children. First generation direct-acting antivirals raised the bar. But we are now in the era of second-generation direct-acting antivirals. They became available in adults in the late 2016 to 17 range. And for children, they are now available all the way down to 3 years of age, most recently being approved early on in 2019 to 2020. So who should we treat? Well, in the era where treatment was not as effective, it really focused on individuals who had evidence of hepatitis by elevated liver enzymes, evidence of liver injury with scarring, or those individuals who had a history of early cirrhosis or hepatocellular carcinoma. Now the paradigm has shifted. The real indication for treatment is presence of chronic hepatitis C with viremia and old enough to take the approved therapies, which is now 3 years of age. One caveat is that the current anti-hepatitis C virus therapies can cause a flare if an individual is co-infected with hepatitis B, so it's important to exclude that. But barring that, the presence of hepatitis C is really the indication for treatment. Miraculously, and thanks to lots of work done by many pediatric hepatologists and drug companies and organizations like the ALF, the FDA has approved multiple direct-acting antivirals for children. There is a smorgasbord of therapies available. You don't necessarily have to remember this from this particular presentation. There's an excellent resource online that gives you the most up-to-date therapies called HCV guidelines, and I refer you to that to get the most up-to-date information. But suffice that, for the genotypes shown here, 1, 4, 5, or 6, many of these are common genotypes in the U.S. and North America. Ladipasvir and sofosbuvir are approved all the way to 3 years of age. They're either oral tablets or oral pellets that are delivered 1 time a day for 12 weeks. I would also note they're approved throughout North America, including Canada and Mexico. This is more of a historic note now because we have pan-genotypic therapies, but for genotypes 2 and 3, in some situations, sofosbuvir with ribavirin is very effective and is also available down to 3 years of age. The dates after these indications are the date of approval by the FDA. There are now 2 pan-genotypic therapies available. GLEC and PRIV, I say that for short, are approved and most recently were approved down to 3 years of age. And for all genotypes greater than 6 years of age, sofosbuvir and valpatisvir have been approved and are very effective. Some of these are for as short a duration as 8 weeks with the newest studies. So what does that mean? It means today we have very safe, very simple, really quick therapies that are very successful. So when I started on this journey with the first trials that I did in interferon with children back in the 1990s, we were looking for the promise of a once-a-day, patient-tailored, single pill treatment with a 95% cure rate and minimal side effects. That is now available for all children more than 3 years of age. But despite that, there remain barriers to cure with these approved DAAs in children. First, Vania talked about this, is identifying children who have hepatitis C. If 75% of children who are born to mothers with hepatitis C are never tested, as was shown in the Tennessee study, we're going to miss 75% of the vertically acquired hepatitis C infected children. So we have to put in screening. If we don't screen our adolescents who are engaging in high-risk activities, we're going to miss them. Once we've identified them, costs can be a barrier, although the costs are coming down in these therapies, and most are appropriately covered by insurance plans. Medical restrictions, such as the need for hepatitis or hepatic fibrosis, are declining, but can sometimes be met. For primary care providers and hepatologists and gastroenterologists, there often can be a fair amount of paperwork around this and appealing for the appropriate patient-tailored therapy. Those can be difficult, but there are more and more resources for you to pursue that. And again, those resources can also be found both at the ALF and at the HCV guidelines website. Once we provide the therapy, we need to make sure that the patients take them throughout their course. 1 pill a day for 12 weeks seems relatively short, but can sometimes be a challenge for adolescents. And the granules and pellets that are available for the 3 to 6-year-olds can sometimes be a little bit of a problem with palatability. Well, we can treat, should we treat, and is it cost effective? Well, several studies have looked at this. I'll show you 2. This study by Nguyen et al. And J Pediatrics showed that if you treat children who are infected with hepatitis C at 12, as opposed to waiting till 18 years or later to treat, there is a significant improvement in quality of life and dollars per quality of life adjusted, all below the $50,000 threshold considered to be high value. And 2 studies have looked to see if treating children even younger, 6 years and above in this case, is cost effective. And it clearly is. It even has a further reduced cost per quality adjusted life year gained after 20 years. And I think we should also think about this not only in terms of dollars, but what is life like for a child who is infected with hepatitis C and for their family? Social ostracization in school, worry about long-term outcome, multiple medical visits for testing. All of this is eradicated with our highly effective curative therapy. So I'd like to summarize this by telling you that hepatitis C in children and adolescents, we've seen the opioid epidemic associate with an increase not only in newborns who are born with HCV, but also in a spike in HCV in adolescents. We can prevent the transmission to newborns by screening of their mothers and identify adolescents who need therapy by screening adolescents. We really need to put together a team effort now. PCPs are a forefront of this. Public awareness is a forefront of this to screen high-risk infants and children as we have readily available, safe, and effective therapies. And really, treatment should be considered and offered to children with hepatitis C as soon as it's identified, as early as 3 years of age. And I'd like to leave you with this last point, that direct-acting antivirals are incredibly effective in children and adolescents, and there are specific drug and dosing guidelines for most situations that will effectively treat all children. With that, I'd like to thank you for your attention and hope that you have a great day.